I'd first like to introduce Dr. Steve Bair. Dr. Bair is an assistant professor in the Division of Hematology here at the University of Colorado. He obtained his undergraduate degree at Seattle Pacific University before going on to complete his MD degree at Case Western. He then moved to the University of Pennsylvania, where he first completed his internal medicine residency and then a fellowship in hematology and oncology, during which he was supported by a T32 fellowship. We were able to recruit Dr. Bair here 2 years ago following completion of his fellowship. His clinical area of expertise is in patients with lymphoproliferative disorders, and his research interests revolve around using big data, EMR-based data, as well as others to improve outcomes in patients with lymphoma, and more generally to spur advances in precision medicine. Dr. Bair will be sharing his expertise with us today with a talk entitled Understanding and Predicting Outcomes in CAR T-cell Therapy for Aggressive Lymphoma. Dr. Bair?
Great. Thanks, Dr. Austin, for that very nice introduction. So my name is Steve Bair. I am an assistant professor in the Division of Hematology. I joined the faculty here about 1.5 years ago and came from Penn. During my time at Penn, I did some master's coursework as well in epidemiology and predictive modeling. And so that's largely where my interests lie. I see primarily patients with B-cell lymphoproliferative disorders. And so my clinical and research focus sort of lie in that area. Here's an outline of sort of what I'm going to discuss with you today over the short time that we have. The framework for my research interests have really developed over the last year or so. And so the development of my own research program is in pretty early stages. So for that reason, largely what I'm going to share with you is sort of the fundamental clinical challenges that we face in this space and the research questions that these challenges raise. And then I'll discuss sort of in broad strokes my research plan for the coming couple years, but then provide some preliminary data as well. So just by way of background, I know not everybody in this audience has a background in oncology or lymphoma. So let me give you a little bit of background here. Non-Hodgkin lymphoma is the 7th most common cause of cancer in men, the 6th most common cause in women. It comprises about 4% of all cancers. Large B-cell lymphoma is the most common non-Hodgkin lymphoma. It's diagnosed in about 19,000 patients across the US every year. About 60% of patients are actually cured with standard first-line therapy, but that leaves 40% of these patients that experience disease progression, often with very challenging disease that requires further therapy, including a therapy called CAR T-cell therapy, which I'll go into more detail in just a minute. It's important to note, though, that in addition to the toll that large B-cell lymphoma places on patients and their families, the economic burden of this disease is also significant. And as just an example, healthcare utilization costs associated with CAR T-cell therapy itself can range between $500,000 and $1 million for an individual patient. So definitely a significant strain on the system as well as the patients. So that sort of speaks to the relevance of the disease, but let's talk a little bit more about CAR T-cell therapy. So I don't want to assume that everyone or anyone in this audience knows what CAR T-cell therapy is. So I'll give you a little bit of a background about the process and the therapy. So this figure demonstrates how CAR T-cell therapies are produced. So patients, once they're sort of deemed appropriate or eligible for a CAR T-cell therapy, they undergo an apheresis procedure where T cells are removed. The T cells are collected and sent to a manufacturing facility where a vector that encodes the chimeric antigen receptor, or CAR, is transduced into the cells, generating a CAR T cell with the expression of this chimeric antigen receptor on the surface. These cells are then expanded in vitro and then sent back to the clinician for subsequent infusion into the patient. The CAR T cells that are approved in the large B-cell lymphoma space all target CD19. So this chimeric antigen receptor targets CD19. It hopefully tracks to the lymphoma cells and induces cellular toxicity. just looking in a little bit more detail, CAR T cell, the CAR receptors sort of have multiple domains. So there are multiple intracellular signaling domains, including CD3 zeta, which is essential for T cell signaling. The second generation of CAR T cell products actually started to incorporate these co-stimulatory domains that are primarily what have made these cells persist or contributed to the persistence and expansion of these cells and their clinical efficacy. There's a transmembrane domain, and then finally there is a targeting element derived from a single chain variable fragment, in this case targeting CD19. So that's sort of a background on CAR T cell therapies, what they are, how they're produced, but how do they fit into the treatment paradigm for large B-cell lymphoma? And this is relevant because this is changing very rapidly. So 5 years ago, this would be the standard treatment approach for patients with relapse or with large B-cell lymphoma in general. So as I mentioned, patients are diagnosed, about 60% of them will develop durable or experience durable remissions that will ultimately translate into cures. But despite sort of a generally effective frontline therapy with regimens like R-CHOP, 40% of patients will go on to relapse or be refractory to that frontline therapy. Historically, the second line treatment has really consisted of more or different chemotherapy, often more intensive chemotherapy, followed by, in patients whose disease responded to that chemotherapy, more chemotherapy and an autologous stem cell transplant. Only about 20% of those patients ultimately would make it to stem cell transplant. The remainder of those patients continued to deal with refractory or relapsed disease. Often additional chemotherapy regimens would be attempted, or clinical trials, in some cases hospice as well eventually. So that's sort of the historical paradigm until recently, and this data actually encapsulates the outcome in these patients quite nicely. So this data is from an international multi-center retrospective study of over 600 patients with large B-cell lymphoma who were refractory to or relapsed within a year after that second line chemotherapy. And so you can see at 2 years out, only about 20% of patients are still alive. And so clearly the prognosis for these patients has historically been dismal. These other curves just shows different subgroups sort of in that cohort, all sort of with pretty poor outcomes. So the treatment paradigm for patients with relapsed refractory large B-cell lymphoma has evolved rapidly, as I mentioned, and this is due primarily to the development of CAR T-cell therapy. There are now 3 FDA-approved products in the third line setting. And so this is just the overall survival figure here that I already showed you. And this actually was the basis for comparison in these initial trials that led to the approval of these drugs. And so this was the overall survival results from the very first product that was FDA approved for these patients. And you can see that at over 2 years out, approximately 50% of patients are still alive. So this really generated a great deal of excitement with an apparent tripling in the overall survival of these patients. So this was FDA approved in 2017. In 2018, tisagenlecleucel was FDA approved based off of similarly encouraging data. And the most recent product was FDA approved last year in 2021. This is lisocabtagene maraleucel. And this, again, showed similar outcomes. So these therapies have all become very rapidly a standard of care in the third line setting. So for patients who progress pretty quickly within a year or are refractory to this second line treatment. And this was the case up until about a week ago, last week, on the basis of randomized phase 3 data comparing CAR T-cell therapy to this second line approach with more chemotherapy and auto stem cell transplant. Axi-cel was FDA approved in the last week in the second line setting. And approval of liso-cel based on similar phase 3 data is expected later on this summer as well. So you can see that the treatment landscape in this disease is evolving very rapidly, and CAR T-cell therapy is becoming increasingly more relevant in this setting. So all this looks great, right? We've made significant improvements. So what are the issues that remain? So no one can question the improvement in outcomes that have resulted from this therapy, but at best, only 40% of patients actually achieve durable remissions, and only 50% are alive 2 years later. So clearly, there's still a large cohort of patients that in whom CAR T-cell therapy may not be the most appropriate therapy. In addition to that, these therapies are not benign. Toxicity is significant and can include a severe systemic inflammatory syndrome called cytokine release syndrome. Severe neurotoxicity can occur in many patients. These tend to be transient and resolve within a month or so after therapy, but can contribute to significant morbidity and in rare cases, mortality. Infections after CAR T-cell therapy can be common. And then, as I've already alluded to, the financial toxicity on patients and their families, as well as the financial burden on the system overall, is not insignificant. Currently, apart from clinician gestalt, we have really a pretty limited ability to predict which patients are most likely to benefit from this type of therapy. So if a patient meets basic criteria, we tend to proceed to CAR T-cell therapy. So this brings up, a clinical problem, and just to kind of summarize, so CAR T-cell therapy is associated with a durable remission rate, but it tends to be less than 50%. And this therapy is associated with a significant risk of toxicity and a large financial burden. So only 50% of patients ultimately benefit, but all patients are exposed to the potential toxicity and financial burden. So there's really a critical need to develop reliable and valid prediction tools to guide our clinical decision-making and therapy selection in these patients. And I think this problem that I've sort of laid out for you is ideally suited to develop prediction models in some ways. And there are a few reasons for this. One is that the outcome of interest is actually quite common. So amongst the population that we're interested in, the outcome occurs, relapse occurs in about 50%. And so that helps facilitate the process of modeling. In addition, there's a short latency period between the treatment and the outcome of interest. The vast majority of patients who relapse after CAR T-cell therapy will do so within 6 months. And then finally, I think accurate prediction really should be associated with a strong potential to mitigate unnecessary toxicity and financial burden. And so these are all reasons why prediction in this setting would be valuable. As I've already mentioned, there are really no currently well-validated tools to predict outcomes to CAR T-cell therapy. There have been a few clinical predictors associated with a higher risk of relapse. I've outlined the majority of them that are published here. And the paucity of well-established predictors is not without trying. There's a great deal of interest in this field in identifying predictors. But most traditional clinical parameters that have been studied and found to be predictors in large B-cell lymphoma actually do not translate to the CAR T-cell setting. And these include factors like performance status, age, the genetic subtype of the lymphoma, at least the genetic subtypes that are most relevant clinically currently, prognostic scores, the International Prognostic Score. These have all been associated with sort of some predictive capacity in large B-cell lymphoma in general, but they don't translate to this setting. So we're left with a few routine clinical variables from which to develop predictive models, which is particularly challenging. And so that raises the problem of data sparsity. And so this can be sort of manifested in multiple ways. There's a lot of interest in using machine learning approaches to sort of understand and predict. That is challenging in the absence of a large number of patients. And clearly, there are not a large number of patients even around the country who are undergoing CAR T-cell therapy. And so There's a limited number of patients. There's a lack of data uniformity, which contributes to data sparsity. So as most of you know, clinical data is messy. It requires a great deal of quality control and data cleaning, and that contributes to the data sparsity issue. And then I think really importantly, and this is illustrated by by thus far the lack of predictors that have been established, a lack of relevant biological data. And so, I often use the example that we have comprehensive metabolic panels, through resources like Compass and other, the EMR and other great resources. I can get the comprehensive metabolic panel for every patient that's undergone CAR T-cell therapy, and more so, I can get every CMP they've ever had. But that's not relevant to the predictive question at hand. And so you have to have the right data. And so that's another issue, is I think we're not really capturing in a routine sense the relevant biological data. So my collaborators and I have really focused on two primary methods to overcome data sparsity issues. Both of these projects are at pretty nascent stages, but I'll kind of go into some detail, mostly about this second approach here. So first, we've generated a CAR T-cell database for the patients who've undergone CAR T-cell therapy here at the University of Colorado. It holds manually curated data on CAR T-cell specific parameters, including outcomes, and we can incorporate pathology data, clinical data, imaging, et cetera. And this data can be merged potentially with other data sets like our primary lymphoma database. Over the coming over the coming 2 years, we're hoping to begin to really establish a database that incorporates some multi-omic data into this cohort as well. And this is really with the goal of both identifying new and potentially novel mechanisms of resistance to these therapies, and as well as to identify potential predictors of response. So I'm not going to say too much more about that. We're still sort of in the planning stages about what makes the most sense in terms of methodologies. But the second broad approach that I'd like to discuss is the use of mechanistic modeling to predict outcomes. And so some of you in the audience might not be familiar with mechanistic modeling. So this is just a very brief background. One definition that I found of mechanistic modeling that I really like, I wrote here. It's a quantitative representation of a biological system whose definition, or the model itself, is really determined and constrained by the relevant knowledge of the system. What's been published, what's been studied about what the mechanisms are. And so in this case, our knowledge about how CAR T cells might interact with lymphoma cells would be encoded in the model itself. There are some advantages to using mechanistic modeling. First, it uses this pre-existing knowledge and estimates outcomes based on individual data. So it provides some level of personalization regarding the dynamics at play. This is in a subtle way is different from machine learning approaches, which estimates outcomes based on population-based data over a large cohort. Similarly, mechanistic modeling has a specific advantage in that it can handle small data sets, which is relevant in this particular setting. And then these models can be adjusted or modified as more biological knowledge is gained or revealed. And so all of these are potential examples. So before I show you some of our preliminary data, I really want to acknowledge my primary collaborator who's done most of this modeling work. This is Dr. Melika Srilansi. She's in the Department of Pediatrics in the section of Data Science and Informatics. So we've been working on this process for some time now, and we have adapted a model published by Sahu and colleagues to predict outcomes in patients with large B-cell lymphoma undergoing CAR T-cell therapy. This model was initially developed and studied in a glioblastoma model. So this is it's based on a biological predator-prey model. It uses ordinary differential equations to model outcomes. So the model equations are shown here on the left. You can see that it's primarily modeling the various states that consist of either cancer cell growth rate or CAR T cell growth rate. So we're really trying to get at the quantitative number of cancer cells at a given time and the quantitative number of CAR T cells at a given time. And there are a variety of parameters that are incorporated into this model, which you can see here. So just of note, with this basic model, our empiric data, our input is the cancer cell rate of change, or the cancer cell number based off of a PET CT scan. And we use total metabolic tumor volume. This is a common way to measure tumor volume in patients with lymphoma. And then other input data included CAR T cell number at infusion. And then the surrogate for that was following the absolute lymphocyte count with time. And so this is one example of the output from this particular model. We've run this model thus far on 4 patients, and the model output is shown here. So let me just kind of briefly explain. This first, so we first estimated the unknown model parameters. I mentioned, there are a variety of these parameters that are unknown, but the relationships between them are known here, and that's the mechanistic part of the model. So we use the data that we do have at hand to estimate the unknown parameters, really using data from the first 9 days after CAR T cell infusion. So we had the initial, the red circles demonstrate data that was empirically measured, and then the curves or the model simulation. So in this particular case, the cancer cell count was known at day 0, and then absolute lymphocyte in the infusion of CAR T cells, the dose of CAR T cells was known at day 0. And then absolute lymphocyte count was used as a surrogate for tracking CAR T cell expansion. And using that data, we estimated the unknown parameters and then obtained a model output, which is seen here on the right over a longer time frame, which is 190 days. And you can see the cancer cell count rapidly declined, which is what we often see in CAR T cell therapy, and it did not recur. In this patient, simultaneously, the CAR T cell count expanded and then declined. And this is often what we see in CAR T cell therapy. This particular patient did not relapse and has been in a remission. And so this accurately predicted the outcome in this particular setting. As I mentioned, we've run this model in 4 patients thus far, and the outcome has been accurate in 3 of the 4, despite really limited and sort of nuanced clinical input data. So I have just a minute or so left here. So just to give you a sense of where we're looking at taking this, this is really a pilot study. We're hoping to expand this cohort. We have data on approximately 80 patients who've undergone CAR T cell therapy here. There are more and more patients undergoing this therapy all the time. And then, as I mentioned, we can refine this model over time. So we're working on strategies to more accurately represent and measure model states and parameters. So for example, there are methods to actually track CAR T cell expansion and persistence over time, rather than using ALC as absolute lymphocyte count as a surrogate. And so we're looking at ways to more directly and accurately measure these parameters. And then working on increasing data frequency. So for example, PET CTs can clinically really only be performed at infrequent intervals. There are circulating tumor DNA methodologies that we're looking at to potentially increase our assessment or our estimate of tumor burden over time as well. So a lot of work to be done here, but I think interesting nonetheless. The second piece that I mentioned, I don't really have time to go into, but I think the mechanistic modeling approach allows us to overcome a robust number of patients potentially that can limit prediction. And then, as I already mentioned, a second problem is, are we really measuring the right data? And so we're hoping to establish a database that incorporates multi-omic data. This is really in the design phase at this point. Our division has pretty extensive experience with single cell multi-omics. There's an ongoing AML precision medicine initiative that has sort of paved the way for what I'm hoping to do in terms of multi-omics work in the coming years. So there's a lot of work to be done in that space as well. So I want to acknowledge my primary mentors. So Clay Smith, our clinical chief, who does a lot of the AML precision medicine work. Tel Bennett in the Department of Pediatrics and the section of Data Science and Informatics, also wears many other hats here on campus. And our lymphoma program director, Manali Kamdar, all have been really instrumental. I also noted Dr. Srilansi. She's been really instrumental and has been a great collaborator. And then my other colleagues in our lymphoma program and our CAR-T team as well. And of course, our patients and their families are the ultimate inspiration for our efforts. So with that, I thank you for your attention, and I'm happy to take questions.
Great. Thanks, Steve. That was a excellent talk with a lot of information. There's two questions. The first from Larry Moreland. I think one of the issues is you've got an expensive therapy with the potential for side effects. One of the things you're modeling is, response to therapy, but I guess when we think not just of side effects or adverse events, but like serious life-threatening, how frequent are those serious, the most severe cases of toxicity, including the cytokine release syndrome?
Yeah, no, that's a great question. So fortunately, across the country, as patients have gained experience with these therapies, mortality, direct treatment-related mortality is quite low. Just as an example, we've had one patient here out of probably 150 patients who've undergone CAR T-cell therapy who's died from, I think that was severe cytokine release syndrome. So mortality related to the treatment is actually pretty low, but it's not uncommon if patients have severe CRS, for example, to spend a week or longer in the ICU, be hospitalized for a month or longer. So that the morbidity is significant.
Great. And then one other question from your colleague, Dan Gerbanow. Modeling is fantastic. One potential concern is that it would fit primary refractory rather than patients that initially respond, then develop resistance. Could this be remedied by monitoring CAR-T numbers over a longer period in patients with the reagents such as CD19 FC fusion?
Yeah, absolutely. That's a great question, Dan. So again, this was sort of the very basic foundation of the model that we're hoping to expand on. And absolutely, I do agree that tracking CAR T cell persistence over time is really going to be a critical part of this. And so we're working on methods to incorporate that, and that requires more extensive data. And often we get PET scans a month before CAR T and 3 months after and 6. And so, if we have the ability to assess CAR T cell persistence via things like methods like flow cytometry or next generation sequencing, those would be really important to incorporate. And there are several institutions around the country that have started to incorporate these into sort of routine practice. And we're working on those methodologies here as well.
All right, great. Thanks, Steve.